Hello, everyone. Many of you know that I've discussed keys to happiness. How do you practice happily? How do you avoid burnout? Well, today's conversation that is about to happen comes about from a direct message that I received from Dr. Cohen. He said that one of his kids is attending medical school, possibly near me, and he asked if I knew anything about this medical school. I said, well, I probably would not recommend my kids to attend medical school now. But he said, well, I would consider maybe thinking otherwise because he's very happily doing what he is doing. He's practicing medicine in Ohio, and he has a different perspective, and I would love to hear about how he is practicing rural medicine in such a happy fashion. So thank you so much for taking the time to share with us your experience, Dr. Cohen.
All right, thanks, John.
Can you give us, Scott, can you give us a little perspective on where you started and how you ended up where you are?
Oh, sure. So I've been in almost like 21, 22 years since residency. I've experienced sort of a wide variety of practices. I started out in Florida for a year and a half employed. After knowing that South Florida wasn't quite going to be where I wanted to be, I had a private practice in South Carolina for about 5 years.
Before you go on, can you tell me how did you decide that Florida wasn't it?
Well, I was on, I guess it's called the Treasure Coast, or maybe the Gold Coast. It's been a while. West Palm Beach area, Stewart. I just had a feeling that family-wise, it wasn't the kind of community to raise your kids. And it just wasn't a sense of community that I kind of have envisioned as life as a physician. You know, when we come out of medical school and residency, we kind of have an idea. Maybe it's a little Marcus Welby type idea that's not reality. But that's what I was kind of looking for. And kind of the economic environment. I respect the guy I joined, but you know, South Florida, as you can imagine, is a very competitive market. And as you know, in urology, to take your oral boards, you have to be somewhere a year and a half. At least that was the requirement. And so I kind of knew after a year that I'd be moving on. This was around 2001, 2002. And that's when the market was pretty tight for urologists, if you can believe that. Now it's, you know, we get 6 calls a day. It was a little tight. So I knew that I think I wanted to be and have my own practice private. And I found a nice situation in a small town, in not rural, but still a small town in South Carolina. I was there for about 5.5 years. And this was a time when a lot of urologists, for economic reasons, had to make moves. No one was really few were being employed. Groups were forming to have their own ancillaries, you know, CT scan. This was, you know, a lot of those incidentals were becoming important. And I realized that if I was going to stay where I was at, it would be more than you know, I'd have to make that kind of investment. And I didn't think I wanted to stay in South Carolina where I was at, get closer to family. So in about 2008, I moved to Dayton, Ohio, which you consider metropolitan, big hospital system, to become employed. And so I was employed from 2008 to about 2017. And early on, we were the first specialty group employed by this giant health system, and saw how the transition and more administrators being hired, EMR developing, more metrics, wRVUs coming into the picture. And that's when the unhappiness came in. So to say practicing urology happily, I thought I would say, well, let's define it backwards. You know, what is rural and what is happy? Well, I say happy is avoiding unhappiness in medicine. So the things that were starting to make me unhappy was chasing the wRVUs, not really having control. I had the busiest of my group. I was doing all the interstitial cystitis, recurrent UTI. I had the most minutes in the OR, but I had the less RVUs because I was trained prior to the robotic era, and my robotic partner, you know, getting much larger RVUs, and I'm slugging it out with a hydrodistension and cystos. And so that was becoming chasing that RVU and not knowing each month, busy, but what's the RVUs going to be? So that was one of the main reasons of happiness. And also too, as you know, many people know, dealing with a large healthcare system, you lose a lot of control of your day, equipment, staffing. So that's when, after my kids graduated, I felt free to look at other options. And that's when I saw one of the many rural opportunities that are opening up. I think mostly because a lot of urologists were retiring. I took over for a urologist that was practicing 25 years in this community as the only urologist. He became absorbed and employed his last 3 years, waiting to try to find and recruit. So I moved into an employed situation with a rural hospital in 2017. And I can say I've found happiness because I'm avoiding a lot of the unhappiness. Nothing's perfect, but I get that feeling I had when I first started where I can't wait to wake up and go be a urologist. That's a little bit of background.
So it sounds like from what I'm hearing you say is you started in Florida and you were dating yourself when you said Marcus Welby days. and you and I have been practicing for about the same amount of time. You finished probably 2 or 3 years earlier, but you realized when you're in Florida that that is not how you want to practice. And then you went to a different South Carolina, and that's when you were getting some. You were hearing or seeing that a lot of consolidation, practice consolidation, and so that they can leverage ancillaries. And that didn't seem to work out for you because you were seeing not the type of patients that you want to see. And I think you said this word a couple of times, which I believe is the root of burnout, root of unhappiness, burnout, control. You didn't have control over what things you have access to, what kind of patients you see, what kind of schedule you have, and which led to where you are now.
And one other thing, just to throw you a curveball, a second career for me, I was an attorney for a couple of years before I went to med school.
I can't talk to you. You're a lawyer? No, bye-bye.
No, that's 25 years ago. I have a law degree. I'm not a lawyer. But the point I'm making is the reason I'm not a lawyer, I worked for 2 years, because I woke up every day not enjoying what I was doing or going to do. And when you reach that point, so that's what happened when I was at the larger hospital, woke up not enjoying what I like to do. And that's when you got to make a move. Another thing, you mentioned control. This might be a little too esoteric, but about 15 years ago at the hospital in South Carolina, there was a presenter at a medical staff meeting. It was a guy, he was from Louisiana. He wrote a lot about physicians, and this before burnout became a big thing. And he had a grid, and one part of the grid was high control, high stress. Had stress. If you're familiar with that.
So you are thinking probably about Dr. Neil Baum.
No, it was not Neil Baum. I know he's from New Orleans. There's because he was not a physician.
Oh, okay.
But anyway, the point I'm making is that we are, as physician urologists, we are in a state of high stress and low control. And low control and high stress is the most at risk. And the example he gave, if you have low stress, high control, that may be something like you're owning a family business that is so in demand. You have control over it, and low stress because you're. So anyway, that's sort of how situation. I was in a very high stress, low control situation. We're always going to be in high stress, but being out in a rural community, a rural practice, solo urologist, I have a fair amount of high control to balance that.
So how did you? So how did you find your current situation or practice environment where a urologist who's been practicing there for 25 years decided to exit? Were you recruited, or did you meet the urologist at a meeting? or how did you end up in Celina, Ohio, with a population of about 10,000? I thought when I practiced in Lake Havasu, that was pretty small. I think it was about 50,000 population. Those were my first 3 years of practice. But 10,000, that's really small.
Well, you got to look at the county. I got about 45 in the county, and the county next door, Auglaize County, which has St. Mary's, and there's a hospital there. So actually, there's a county hospital in St. Mary's and a county hospital in Celina, and they actually, one employs me, but they joint venture and split my costs. Now, how did I find this? I got to be careful with HIPAA, but let's just say I was doing a urologic procedure on a patient, and I said, remind me what you do. We talked about this. He says, I'm a healthcare administrator at XYZ. And I go, where is that? And he said,
I know someone who may be able to get you something.
No, and he said, we're looking for a urologist. So I remember, you know where my hands are where I'm doing a procedure, and I twist harder and say, make me an offer I can't refuse.
I love it.
And he did. And I called the next day and said, was that the volume talking? Or did you offer me X percentage MGMA? They said, no, that's the offer. And 90 days later, I moved. So
wow,
that's exactly how it happened.
And even
though it's an hour and a half north of where I was at, I still had kind of never heard of that county,
Of course. And this perfectly illustrates the point of, well, number one, talking to your patients and taking interest in what they do. And number two, just being open to different opportunities and looking at these different opportunities instead of just having a closed mindset. I can't tell you how many type of, businesses, if you will, or different things I learned from my patients, including an investment opportunity that I learned through one of my patients, ended up being pretty involved and with a very handsome return. And that venture is not over yet, but you always are looking at different opportunities. So that's really awesome that you were able to find this practice situation in Ohio. Now, when a lot of people can end up in your situation, finding a job in a rural community, how is this not a treadmill for you compared to most people? How is this not a frustrating experience where you have less control?
Well, one thing I wanted to backtrack a bit, that when we, as physicians from our era, you always envision, or maybe we had a cousin, an uncle, a friend's father, physicians stayed in their area their whole life. A lot of urologists of that generation, they've been there for 30 years. Yet you may have had growing up some neighbors, kids whose parents, they moved every 5 years. He was an engineer for General Electric something, and they were of the mentality. So we always feel that as urologist physicians, we're stuck, or we don't want to move. We don't want to uproot our family, but majority of people do. In this situation, my kids were just off to college. But so you say, every urologist particular can find a new job tomorrow. There's so much out there. It's a matter of the mentality or desire to move. And I get that, not wanting to move, but there are a lot of friends and family that move every 4 or 5 years for a job. So that's how I was open to moving. Now, how do I stay off the treadmill? I'm probably still on the treadmill because I'm the only urologist in 2 counties, and I take call 365, 24/7. You might say, well, that's nuts. But if you're in the right county with the patient demographics are very good, where you have good patients, and it seems to not be so much running on the treadmill, and also knowing that the compensation is not based on that. So my compensation, I'll share, is I wanted 75% MGMA with a benchmark of doing 50% is a benchmark of RVUs. And the 25% differential, I said, that's what you're paying to get me to be here and to not have to worry about locums or call or anything. I'm always on call. Now, I'm fortunate that I'm 45 minutes away from a tertiary center and another 50, 60 minutes to Dayton. But I don't dump on those urologists there. In fact, I take some weekend call for them. So not really locums. It's about 45 minutes, and they've allowed for that differential so that if I am not available out of town and I'm not here, rather than being on some communities, which I see from locums I've done, where the ER says, we have no urology, we need to transfer, my ER will call me, whether I'm in the Caribbean or elsewhere, and I'll pick up the phone, and they say, hey, we got this guy here with a stone. I said, well, I'm actually coming back tomorrow. That's okay. You talk the ER docs off the cliff. No need to transfer for perinephic stranding. All right. Oh my God, a fornicel rupture, a creatinine going up to 1.8. I tell the ER docs, hey, that's fine. I'll be back in 2 days. As long as there's no fever, you know the story. So, but if a patient needs to be seen, they'll send them up to the big town. And those urologists there aren't thinking, oh, Cohen's dumped on us again. I give them a courtesy text. They've got PAs. They're a 4 or 5 person group. And that patient gets taken care of. Now, how many times in the 5 years have I had patients? I can count 10 times in 5 years that a patient had to be transferred while I was gone.
So the hospital system is extremely grateful. So it sounds like you, even though the town is only 10,000, you have a large encatchment area, which is similar to where I started in Lake Havasu. Even though the population is about 50,000, the encatchment area is quite large. So it supported 3 urologists in Lake Havasu, believe it or not, when I started.
Well, my county and the other county each support about a half a urologist. Even though Lima is 45 minutes away, they don't take a large amount or below. So it's easy to keep the patients. And part of it also too is what I do. I don't do the big surgeries here. I wasn't in the robotic era, and I think prostates should be done robotically, and kidneys. And I have some great referral options. Columbus is 90 minutes away. There is a dedicated robotic urologist at various centers in Columbus, where I've developed a relationship. One guy's named Ronnie Abaza. I'm not sure if you heard of his name. He's done, thousands and he's up there with a lot of the big guys. And I can text him, and I refer where his name is known in the community. So I kind of tell patients this, I'm sending you the guy that I would personally go to. And after he sees you in a stream of follow-up, you're back to me. You're not going to have to drive an hour and a half for the rest of your urology care after the immediate. So I've developed a referral pattern, so I don't have to do some of those big cases that I did previously. And it helps because, I don't have invasive cardiology here. I don't have interventional radiology. I don't have neurology. So there are a lot of things I don't have where I cannot do the big stuff. But I'm able to do, stones, BPH, the stuff that I guess I hate the term. The only term worse than living the dream is bread and butter urology. I don't like that term, but in reality, that's what you end up doing is bread and butter urology.
There's nothing wrong with bread and butter urology, which is what I do too. And I think you have to know what makes you happy. That self-awareness. For instance, you knew that South Florida wasn't the right place for you, and you knew enough to move somewhere else. And then when the opportunity hit you, you knew, okay, I know I want, this is what I want to do, and the timing seemed perfect. So you've been in Celina, Ohio for about 5 years, and it seems like an ideal practice where you're at 75th percentile MGMA, but the wRVU production is expected at around 50%.
Right. They're not chasing that number, every because it's pretty easy to make. I don't say easy, but I'm pretty close to that 75th percent wRVU, but I'm not worrying about it. We talked about suprapubic catheters earlier. If you change the suprapubic catheter in your office, I don't know if it's much wRVU, but there is. Is there much wRVU for SP tube change, or is it mostly ancillary revenue?
No, I don't think there's a lot of work RVUs for changing a suprapubic catheter. Usually that's a medical assistant who does that.
Right. But I'm saying, but for someone who is in private practice, a suprapubic change in the office, a medical assistant can do it, and I believe it is a revenue plus encounter. Would that be correct to say that?
Yeah.
Maybe $80, $100, and you're there in the office while you're doing other stuff. So the example I'm giving you is, I'm not bogging down my office with that. I'm sending them over to the hospital's little outpatient center, which is down the street. So I don't change suprapubic tube unless there's a problem. And now, so that doesn't bog my office down. And that also gets to another point, is staffing. I run my clinic with, I just ended up getting a PA about 2 or 3 years ago, a half-time PA, to see some of those easier things, post-op stones and things I don't want to do or like to do. I don't like doing metabolic workup and all that. So she'll do that. And then I only have maybe 2 others. I have a receptionist, a full-time RN, and a floating RN. So it's a pretty lean staff. And the reason I keep an eye on the cost, not because it's out of my pocket, but I want the hospital to always see that the one urologist revenue center is cash positive for them, so that they're able to pay the going rate for a urologist.
Well, I can tell you are definitely way cash positive because of all the ancillary revenue that you generate for the hospital. For instance, having that suprapubic catheter changed in the outpatient center in the hospital is creating a lot more revenue for them. In addition, all the x-rays, the labs, the EKGs, all the interventions that you have the hospital do, they're making a lot of money. And I think I posted in the Thriving Urology Practice Facebook group about 1.5 years ago. The average urologist generates over $2 million for the hospital annually. So yes, you are definitely cash positive. MGMA is great. MGMA data are from survey data, self-reported survey data. And and I'm going to make this statement, and I made this statement before, for most private practice urologists, MGM data are underestimating what other urologists typically produce in private practice. So I'm just throwing that out there, and I would love to hear the audience's comments. If they disagree or agree, let me know. But I think that's what it is. So anyway, take that for how you want to take it. But it sounds like you have a good deal where you are not having to worry about the work RVU production. You're easily meeting that, and you have a happy situation set up.
And one thing I just want to clarify. So if I have a patient whose insurance is unfavorable, I'm going to change that in my office so that patient doesn't have to have that huge add-on fee the hospital has.
Yeah.
And I have a couple of patients that do that and have asked that, because when you've, so I'll throw that out there as well. But yes, unfortunately, compensation drives a lot of happiness. And so I've kind of eliminated that. I feel I'm getting paid appropriately. But the other thing too is to keep in mind is our operating room. I can say that being the only urologist, I happen to like Boston Scientific. That's what I have. I like Wolf scopes. Finally I said, I want the next scopes to be Wolf. I like Stort's camera system. The orthopedics, those guys like that, what's that?
Stryker.
Crap? What's that?
Stryker.
Yeah, they like Stryker, and that's crap for urology. I lost that battle. I got Stryker crap that I have to, if you get a little bit of blood, their software doesn't show good imaging. So they aren't perfect, but there's a lot because I always say, urologists don't always play well together unless they're at a group talking about their lithotripsy deal, which, I got a lithotripsy group that I'm part of in the area, but I don't have to fight with other urologists about what I like. Even then you have issues. Oh, yes. Oh, yeah. So I have an OR environment, and also because I use some of my vacation days is being employed. I use some medication that I don't use, and I do some locums. I was in Fargo, North Dakota 2 weekends ago because of the extraordinary amount of desperation and funds that patients pay. And big, huge center. It does a couple things. I still got it. I can do a level 1 trauma referral center for as a urologist. So I still have the skill set, because I don't get many 4 years gangrene here in the nice, clean rural environment. But, so I feel I kept my skills up, but also I can see how the equipment and it's different because they're having to keep so many urologists happy, where if you're the only game in town, you can generally get that basket and that size stent that just you like. And that's a lot of happiness in there. I don't know if you struggle in your OR where you do your stones and you or other people do where.
Yeah, getting the equipment that you like is definitely important. I'll give you an example. I recently started working at a surgery center, a different surgery center, and they had urologists there. But I think a lot of urologists don't care, or they don't voice their opinion, or maybe it's just too much hassle to talk about what they want. But the first thing I did was, I think they had a Stryker camera system, but it doesn't have an articulating head. You know what I'm talking about? Where the camera is affixed to the cystoscope, and when the scope turns, for instance, if you're doing TURP or TURBT, the coupling does not rotate. So that means you're literally friction anytime you turn the scope. So I'm holding the camera, and then there's friction whenever I turn that scope. They dealt with that for years. And one of the first things I said was, come on, this company has to have an articulating coupler. And sure enough, within a couple of weeks, I trialed one. They purchased 2 of these articulating heads. It just, the simple things like that. Not many people want to take the time to fix it. At my hospital, it was a fight to get a new Olympus camera system many years ago. I literally brought in my own monitors so I can get a better image. Because I told the CEO at that time, you wouldn't want me to perform your bladder cancer surgery using your current system. And the response was, sorry, it's not in the budget. Well, anyway, I took to social media, which got me into trouble with the medical staff, and we got our system. Not only did we get one, we got 2 video systems. Now I can say I'm happy and I'm proud to work in this hospital where they have the best equipment that I would want used on me if I were the patient, not back when they had the equipment. Gosh, I started with this hospital before it opened back in 2005. So they had the same equipment since 2005 until recently when I said, nope, we need to upgrade. But anyway, I totally get what you're saying. But the underlying tone is that you had control. You had the ability to say, this is the camera system that I like. This is the laser. Here are the instruments, the baskets, the wires, the stents that I want. And you're able to have a say-so in getting what you want. In a larger system, you have a lot more people that you need to placate, a lot of other urologists competing interests, even though in this situation at the surgery center, it seems like nobody's mentioning anything. But I totally get what you're saying. It's that sense of control.
And also, too, it's also not going in there guns a-blazing. The big thing now is laser. I trialed both the Olympus Soltive, and I trialed the Moses.
Oh, okay,
and
Moses.
For certain reasons, I like the Moses. It's twice as much. But I go into the CFO's office and I say, I want this. I gave him an example and reasons, why I liked it and how. And this was a kicker. I was able to trial both of those. And when you trial, they usually give it for free and give you the fibers. I said to him, I saved you $60,000 by trialing each of these for 3 weeks each, because I loaded up the patients. $60,000 that you didn't have to pay for. So you add that $60,000 to the cost of the Soltive, that equals the Moses. And not to get too into this, but I'm not going to do enucleations, but I like the ablations. I said, and you're not going to have to spend $2,000 a case for green light anymore. So I spelled it out to him because he didn't know urology. And I said, your ROI is going to be 2 years. And that's what they want to hear. So I'm getting that Moses laser the first of the year. And that's the way you got to kind of work with them. And so I can walk right into the CFO's office where you can't always find him in a big hospital. So that helps too, not just being the troublemaker urologist saying, get me this or get me that, or, I'm your only guy in town. You got to think that, but not say that to them, and kind of do the thinking for them.
Well,
and
I think what you were saying, your instance or example, is a great illustration of empathy. You're empathetic to the CFO's thought process, which is ROI, return on investment. They are into finances. You told them that you saved them $60,000 by trialing these 2 lasers, and you stacked those cases. They were able to do them for free. You spoke his or her language, and that's the key. Standing in the foot of the person that you're speaking with, and then being able to think about or say the things that he or she is thinking and addressing those concerns, showing that you respect their perspective and you've thought of it, and this is why you should think things my way and do things my way.
Exactly. Doesn't always work, but that back to the thing, that's, you can do that in a rural setting, and it takes away the unhappiness of having the technology that you say to yourself, I wouldn't want a urologist using this technology on me. One final thought to that, because of course this hospital finally got itself a robot, claiming they're not going to be able to recruit gynecologists and surgeons. And he said to me, are you going to do prostates? You're going to learn. And I looked at him and I said, John, his name was John, but not to give up, but saying, do you want me to do my prostate on you when I may do 12 to 15 a year? Or do you want me to send you to Columbus, the guy does 10 a week? Who do you want to do yours? And he looked at me and he kind of realized that. Now I got to work with him. So I said to the urologist, why don't you take your vacation day, come here to my town, do robots with me. I will assist you because I've assisted in robots. I don't care about the assistant fee or RVUs. They'll be able to pay you maybe a day locums fee. It's worth your time. We already have a relationship. Patients will love it. And then my hospital is using the robot, and my patients don't have to drive 2 hours. And that's great. I don't know if he's going to buy into that or not because he's so busy. But that's the way I'm trying to think. All right, let's bring a super surgeon to our town to do robots with me. And the patient, if you tell that patient, he'll meet him preoperatively, but you can work with the patient or Zoom so the patient feels he has the relationship with the billing physician, but they know that I'm there for them. And that's how the robot will get utilized in this small community by an expert, not someone that doesn't have big numbers. I don't know what your thoughts are on that concept.
Once again,
with the CFO.
Once again, so much self-awareness of what your capabilities are and doing what's good for the patient, and also thinking out of the box, having the expert robotic surgeon come into your rural community and set up cases for him. And not only that, you are in the room assisting with those cases, so your patients don't feel like they're having a procedure done by someone they don't know. You are going to be in the room. I think that's a great way to think about things, and you're setting it up ideally in your situation. So these are some of the examples, some of the things that I think other people want to hear, because a lot of urologists are very keep things close to their vest. And what I'm trying to do in the Thriving Urology Practice Facebook group and everything that I do on YouTube is to get rid of that. Get rid of the silos of knowledge and information so that everyone can benefit, and ultimately the patients will benefit. So I think that's a great idea. Thinking out of the box, having that person come into your area and you kind of teeing up everything. The patients are happy. The person coming in is happy. The hospital's happy. So you're making truly a win-win-win situation.
Yeah, and if I can close with two comments that I did want to get in. The first one is I wanted to thank you for your Thriving Urology Facebook page. It's a nice mix of information, business, fun. When you say, what do you guys do for fun? You've mixed it very well, and I enjoy that. The second one is maybe a little bit of apology on my part. I'm also on some Facebook groups for some hobbies of mine. Like beekeeping, I told you earlier.
Yeah, beekeeping.
And there are some people can be cruel when you throw an idea out there about which type of honey extractor you like or something. So in the heat of the moment, I made a comment saying, InterStim, bullshit or a good tool. And I want to apologize because I'm realizing, well, the moment was someone had come to me who had one not working. It was put in by someone who's, I think, putting too many in. But I got to pull back and say, I called something bullshit that many urologists use and like it and works for them. Now, I didn't call it bullshit, but I said, is it? But anyway, I realized I used the heat of the moment that could have offended some people, and I apologize for that, in sort of implying that. So it's just a cautionary tale for people in the group to always be careful what you say because it can rub someone the wrong way. And no one responded negatively, but I want to say that people are using InterStim and having success. That's great. And it can be up for debate what's better. But I apologize for going down that road of being kind of like an angry Facebook group poster.
Well, I think those potentially incendiary posts are the ones that generate the most interest and discussion because we all, as you know, opinions are like a-holes. Everybody's got one. And I belong, and I don't run many of those groups, but I belong to a lot of groups. One of my interests is photography. You see that on my personal profile. So I take a lot of photos and photography. You talk about being passionate about a certain mode to shoot in, or certain lens to use, or certain camera to use. You can become really opinionated in photography. So I totally get it. But I appreciate all perspectives. There are some people's views that I don't agree with, but that's what's so great about this country. You have the First Amendment to protect your freedom of speech, and a lot of people don't realize that most countries do not, including Canada, Germany. They do not have the First Amendment to protect all speech. And I will say something controversial. There is no such thing as hate speech. So I'll end with that. But I truly believe in the First Amendment and freedom of speech, and so I appreciate any and all posts from anybody, whether or not I agree. It's great to hear other people's perspectives. But you have InterStim. That's what's so great too. You have InterStim, you have Axonics, now you have Cohen, you have Blue Wind. That's a huge underserved population of female urinary incontinence. Sacral modulation and peripheral nerve stimulation, I think, is going to undergo a lot of changes. But as you know, a lot of it is just legislative policy, the CPT codes, and reimbursement. And speaking of assistant surgeon, I want to just share with the audience that when you are an assistant surgeon, make sure you use the appropriate modifiers, 80, 81, possibly 82, or if you're an APP, assisting modifier, Alpha Sierra AS. That's a Hicks-Picks modifier. So anyway, final words, Scott. I appreciate you sharing your thoughts and taking time out of your Sunday morning to share your wisdom. And I'm also grateful to the gods that internet stayed up in your rural area.
Oh, yes. Thanks so much, Sean. I really enjoyed it and look forward to contributing more to the Facebook group.
Yeah, you bet. And I am going to read some comments. Shauna Lee, what if you enjoy it, but the lack of control puts it in a place where you can't maintain the pace?
Well, I kind of, every now and then we kind of think things out. That's when you go full-time locums. You have all the control, and the pay scale locums is approaching pay scale of a full-time urologist, but half the time. It's quite a challenge. I'm not there yet. I like my community and being a part of it. But if I ever lose that control or that, be a road warrior and do locums, and then you have a lot of control at that point.
And here's another comment from Shauna as well. What if you have the right place but wrong group? How do you evaluate a group you might join?
be solo and don't join a group. Be a solo urologist employed by a place that has no urologist, I guess. But we don't have control over our primary care that refer to us. And that's a whole nother conversation of how, as urologists, we do a poor job of educating our primary care. Think about it. I think in 10 years, we're not going to have MD primary care or DO primary care. It's going to be APPs. And what training are they getting in urology? They're getting nothing, or from their predecessor. And as urologists, how are we educating our primary care about the guidelines of PSA? We'll complain. 85-year-old comes in for an elevated PSA of 5.1. Well, quit complaining about that APP. They'll hear about it and won't send you anything. They'll send it 45 miles out of town, but got to take the time to educate them. Now, I'm all talk here. I have not yet put together the time to do that, but I've been wanting to at least do some education. So that's how we can kind of get control over our referrals, by educating. If you remember, John, I used the example of Vesicare. Remember, was it 12 years ago? Vesicare was launched not to urologists, but to primary care. Do you remember that? And think of that, the day when primary care took care of the first line treatment of BPH and overactive bladder. Now I'm getting initial consultations from APPs and some MDs and DOs. Someone seeing you for urinary frequency who have not been tried on anything. But can you blame them because they're told anticholinergics makes them all have dementia? So I can't blame them for that. So we need to do a better job of educating, to answer the question, to then have a group, meaning in our healthcare group, the referrers, to be educated. It's tough to do, but that's something we've ignored. What are your thoughts on that?
Yeah, I'm going to flip the script in that you don't need primary care referral if you do a good job with your online reputation, if you have an online presence, if you have online Google reviews, for instance. That is the most important thing. If you can go, what pharma has done for 30, 40 years, if you can go direct to consumer, that's what all industries do. DTC. You don't need to rely on anybody, any system, any primary care for your patients. You do a good enough job. You let everyone else know organically and indirectly through social media, through your educational YouTube videos, educational Facebook posts. Patients will find you. So you have the direct person-to-person word of mouth, right? That's in the old days. It still happens today. But what happens when you get that word-of-mouth referral initially? That person whom you referred is going to check you out online. So they're looking for that social proof, secondary validation. And if you have that, you can eliminate the middle person, which is your primary care. And then the world is your oyster at that time. I have actually, my biller just told me this past weekend that a patient is flying in from Florida to see me for a potential TURP. I mean, come on, anybody can do a TURP. But because of what I talk about my experience, how many I do, my outcomes, and how it's an outpatient procedure with a catheterization time of maybe 1 to 3 days instead of weeks, patients will see that or hear that, and they hear about my patient's experience by getting video testimonials of my patients. So I'm going directly to consumer. I eliminate the middle person, and that's one of the things that you can be happy. You don't have to be beholden to anybody else. And educating primary cares, I think that's extremely important. I still do it to some of my local primary care docs, mainly about BPH because I enjoy treating BPH. The other thing I try to educate them about is that medical therapy is not necessarily the only option, nor should it be just the first option, because I treat a lot of patients who don't want to be on medical therapy. They want a cure so they don't have to be on medication. And there are some dangers with anticholinergics. I'm very, very thankful that beta-3 agonists are available now, Gemtesa, Myrbetriq,
but not paid for. That's a sore spot.
Right. Cost is always a problem. Over time, it becomes generic. Thankfully, it becomes a lot more affordable. But there are assistance programs with each one of those medications for the patients. However, it requires more work. Again, more hurdle for your staff, and it takes away resources that can be spent on taking care of actual patient issues instead of logistical issues. So anyway, just some food for thought.
Absolutely. Absolutely.
And Shauna also said, your hospital can hire a robotic locum through Dr. Ian Thompson's locum program. Dr. Ian Thompson is a urologist, also in the Thriving Urology Practice Facebook group. He is also running a side gig of a locums company, and you can maybe contact him or DM him and have things set up. And if you want his contact,
remember, but I want the person that I've worked with or have a long-standing working relationship, not just some mercenary to come in and do it, because then that builds up the reputation, which that referrer already has a reputation in town where word of mouth. So that is the what's pushing that. But I get that too. But one important thing too is I don't want the hospital to pick someone. They need to work with me, the urologist. So that's an interesting concept.
Well, you can be the facilitator. You can be the person who says, "Hey, this day, this week, this weekend, or whatever, I vetted this urologist who you may have gotten in contact
That's interesting.
with." Yeah.
If it doesn't work out, you say it's Ian Thompson. I know I've heard the name, and so that's a good out. Oh, I thank her for that.
Yeah.
If I can't get it to work out, and if I can kind of, I don't want to say I'm all knowing and I'm vetting, but I mean, have a conversation, know that I have the same kind of philosophy of, you don't want to have, if say you're a locums robotic, you come in and then in front of you is someone who should be active surveillance, that would push, well, I'm here and I guess I got to do this robotic on him. But in reality, back of your mind is someone that you feel strongly you would watch. So it has to really be a tight relationship.
Yeah. The practice philosophy has to be in alignment for that disease state. Otherwise, when you have that incongruence between the surgeon and the referring urologist, that can be an issue.
Oh, that's an interesting opportunity for Ian Thompson to.
Yep. And Karen, more comments here. Karen says, thank you for this interesting and informative topic. So thanks again, Scott. And Danielle says, thank you. I enjoy listening to your talk. Shauna also said, so many primary care doctors comment about how much they learn from my notes. I assume that she's talking about referring notes back to the primary care doctor, which is a huge issue, believe it or not. When I first started practice, I don't know about where you are, but when I first started practice, I went around the primary care docs and I asked them, what don't you like about your current urologist? What don't you like about the people whom you send your patients to? And they said, one, being seen in a timely fashion, and number two, getting the notes back in a timely fashion. So those are the things that I addressed ever since I started practice. But how do you educate your patients, Scott, through your notes, or through your primary care doctors through your notes?
Interesting. So we'd get a note back, and it'd be 5 or 6 pages of EMR garbage. So I made when I first started out, even when I didn't have an EMR, I want my note to fit on one page if possible. If that means changing the margins, this is back when we had a typist and a Word, you'd send changing. I told my transcript, change the margins to 1/4 inch on each side, one page. And then I wouldn't do, and I also don't believe in the extra paragraph of, oh, thank you so much for letting me participate in the right care. I basically just copy the note to the primary, but the first paragraph is not, the first paragraph is impression and plan/discussion. Then there's a big line across. Everything below the line is just to get my bullet points. This is back in
Hang on, Scott, I got to do this.
Okay. So it says impression, BPH and medications is not working for him. Plan, I think he'll do fine. He'll do well with a procedure. We're going to follow up for a cystoscopy, and this is what we're going to do. And then I send a copy, and I've had comments from my primary care Sorry if I'm getting loud. I'm just very excited about
I
this.
love it.
You hope you're controlling the volume. But
I am.
my primary care respondents saying we love your notes. They're not like having to read 5 pages. Say, what did he say? It's there in the top and a big line across, and basically ignore everything below it. That's just for me to get my 99214. That's how I try to educate them through my note.
Man, Scott, I love this conversation because so many things, we can go into so many different directions. So number one, you don't need that, I call it logorrhea, diarrhea of words to get a 99214 anymore. That changed in 2021. So for the listening audience who are APPs or physicians, you don't need to write a dissertation to get a level 4. For billing and coding purposes, a single problem that is worsening, requiring medical drug management, that's a 99214. So think about that. Think about all the BS that you're writing, all the stuff that you're documenting in your EHR, the 12-point review of systems, that is no longer necessary. And we talked about that this past weekend at the Urology Advanced Coding and Reimbursement Seminar put on by the Painters, PRSnetwork.com.
And I've gone through them.
Yeah. So,
and the secret coming up, inpatient consults are going to be the same. I can't wait for January 1st. So, because I always low ball all, because I still have some inpatient consults, because I just don't want to go through all that crap of making up stuff for review systems. So now my billing is going to go up January 1st because we look at all our own films, correct? If someone has had a film, look at them, you're almost 3/4 of the way to a level 4. All you got to do is have a new problem and prescribe a medicine and look at the films. That's your level 4.
So look, okay. Personal, let's go into details a little bit about E&M services. Number one, yes, the hospital. So CPT is bringing into alignment since the 2021 E&M changes. E&M changes in 2021 applied to outpatient services, office and other outpatient services. In 2023, hospital evaluation and management is going to be in alignment with the 2021 outpatient and office and other outpatient services. So the way you evaluate and code and the criteria that you have to meet for now the hospital and the office will be the same in 2023. So that's an important change. I won't go into that, but that is an important thing to know. And when you say that personal evaluation, you personally interpret the images, you look at the images and you interpret it, that's a independent interpretation of imaging services. That is a level 4 data point. And those of you who are astute coders or astute physicians, you know that in 2021, you just need 2 of the 3 components to reach a level when it comes to coding and billing. If you're billing by medical decision making, you need problem, you need data, and you need risk. So when the data is a 4, you just need a 4 on a problem or a 4 on the risk to get to a level 4. And I will caution everyone to remember that it is no longer a new problem that matters. Is it a chronic problem? Is it a chronic problem that is stable? Is it a chronic problem, not a treatment goal that is worsening? Right? So chronic stable problem is a level 3 problem. It doesn't matter if it's a new problem to you or the patient. It's a chronic problem, or it's an acute uncomplicated problem. So those concepts you need to understand. It is no longer a new problem, an old problem, but is it a chronic problem? And is it an acute problem? Is it getting better? Is it stable? That's what drives problem. And a caveat, another aside, is that it is not a diagnosis. It is a problem-based coding setup. And
as I believe that the painters say in one of their talks, not being at therapeutic goal is a problem that is not, so I like to think of it as, are we at a therapeutic goal? He's on his Flomax. The symptoms are the same, but he's still getting up 2 times at night and he's not happy with it. He says he's not at therapeutic goal. There.
And here's another caveat. And here's another caveat. That therapeutic goal is your therapeutic goal, is not the patient's therapeutic goal that you are using to guide you when it comes to problem. So you can have a patient who with an AUA symptom score of 23, who's on tamsulosin twice a day, who enters on the bother score of 2 or 1, and he's in retention. So the patient is not bothered. He's saying that I'm happy living like this for the rest of my life, but is it the best thing for the patient? No. In my opinion, that treatment is not a treatment goal, which means that, for that BPH example, will be a chronic problem, not a treatment goal. That's a level 4 problem. And the patient, if he decide to continue on that tamsulosin BID, even though the patient's not a treatment goal, you talk to him about the other treatment options and you truly manage the medication, not just simply renewing the medication. That's a level 4 risk. So now you have a level 4 problem and a level 4 risk. That's a 99214 or 204. Anyway, so we digress into the nitty gritty of medical decision making and coding and billing, one of my passions. And I've done several videos on YouTube and in the Thriving Urology Practice Facebook group about modifiers and E&M coding.
That's how I found you, from the painters PRS community. Not as active, and then I saw someone reference you and that's how I found you a year ago.
That's great.
So thumbs up to good plug. And if I can plug too, I don't know. There's a guy that does an E&M University, very affordable. You get CME for it, and he really explains. It's mostly primary care, but I've really enjoyed the video presentations with the new 2021, where he's on our side. He cuts through all that stuff and uses a little bit of analysis of, hey, how much time are you putting in for your code? Have you seen his stuff before?
No, I haven't.
I think I started to the letter EANDM University.com, and I think you'll find very, very, very insightful. Is a nice adjunct to PRS.
That's great. That's great.
Look at that.
Yeah, PRS is urology specific, and that's why the examples are a lot more relevant and people get it in our field. All right. And let's see. Gosh, we got more comments. Shilpa said, thank you. Learning so much about urology and practicing appropriately. Appreciate your time. So thanks again, Scott. Shauna said, I quit my regular job, and that's what his concept is, or what your concept is, Scott. Quitting the things that you don't enjoy doing. And Shauna also says, yes, thanks for your talk. All right, Scott. I think we dragged this on long enough. Once again, thank you so much for being such a awesome guest and talking about what you went through and your experience. I think this is going to benefit a lot of people who may be stuck in a rut.
All right. It's been really a pleasure.
All right. Thank you so much, Scott.
All right. Take care. All right.
All right. Those of you with any additional comments or questions, please feel free to leave them below. I always appreciate the opportunity to be here and the privilege of your time. Please take care of yourself and take care of each other. Bye-bye.